Good afternoon, everybody. I'm Adrienne Bridenstine. I'm with Behavioral Health System Baltimore. Thank you for coming to this exciting announcement today. We are here to give you an update on the 911 Diversion Pilot Program. And I am very pleased to be introducing Mayor Brandon Scott.
Thank you, Adrienne. Thank you so much, and good afternoon, everyone. It is great to be here, but in particular to be here with such a dedicated group of people who have been doing and leading this great work. You already met Adrienne Bridenstine, Vice President in Policy and Communications here at BHSB, but we also have Krista Taylor, President and CEO of Behavioral Health System Baltimore. We have Jonathan Davis, Executive Director of Baltimore Crisis Response, Inc., the fabulous Tania Reddick, the 911 Director with the Baltimore City Fire Department, Dr. Ben Larner, Medical Director also with the Baltimore City Fire Department. We have Shannon Sullivan, Director of the Baltimore City Police Department's Consent Decree Implementation Unit, and Captain Jai Eduardo, who's also with BPD, and Terry Weathers and Alana Jones here representing our fabulous United States Senator Chris Van Hollen to talk about the critically important work being done through our Behavioral Health 911 Diversion Pilot Program. But before we do that, I also want to highlight Allie Smith in my office, who's been on my team leading and helping and coordinating this great work, and thank her for her great work, as she did not mention herself in my talking points today. We want to thank you, Allie, for dedicating yourself to something that is innovative but definitely necessary for Baltimore to move forward as a city. This is something that I have been passionate about even before I took office. And immediately upon taking office, directed our agencies to develop a 911 diversion program for behavioral health. This month marks 1 year of the implementation of this program. It is about matching individuals to the most appropriate and available resource when they call 911 for assistance and reducing unnecessary police encounters with people experiencing behavioral crises. This approach aligns with the SAMHSA guidance and evolving best practices, and we are leading in this country, in this nation, with this work. 911 diversion aligns with the requirements of our federal consent decree and demonstrates my commitment to addressing gaps in our public behavioral health system. Currently, Baltimore receives an average of about 13,000 911 calls for people in crisis, often mental health or overdose emergencies. And frankly, we do not need to and should not be providing a police response to calls that are better handled by trained professionals. As a country, we need to stop looking at our police officers as the solution for all of our problems. They are not trained for this work, and their time is better spent doing what our residents actually need them to do: proactively policing and catching violent criminals. We started this pilot small because this work was too important to not get it right. We have an interagency team that meets regularly to review diversions and provide quality assurance. It's through this process that we've been able to develop a process that provides the best response to those in need and determine how to successfully expand this work. The 911 call center initially started forwarding two suicidal ideation call types to the Here to Help hotline operated by Baltimore Crisis Response, Inc. And in April of this year, the pilot expanded to include a similar third call type. We have great champions and our federal partners on Team Maryland working on behalf of Baltimore in D.C. And recently, our wonderful Senator Chris Van Hollen secured $2 million to support expanding this diversion program. We want to thank him again today, and you'll hear more about that expansion from Krista in a second. I want to give a big thank you to our incredible federal delegation for securing this money to help us continue this greatly important and needed work. I also want to thank Behavioral Health System Baltimore for developing the earmark proposal. You know, if you know anything about me, you know that I believe data is the cornerstone of good government. If you can't measure it, you can't improve it, and I am determined that progress can and should be measured. It helps us set and track goals, allows us to be transparent, and forces us to be more accountable to the public and to ourselves. As I often say, men lie, women lie, but numbers don't. through the Data Fellows. Yes, I knew you would appreciate that, Doc. Doc is a Jay-Z fan. I just found that out just now. And through the Data Fellows Program in the Mayor's Office of Performance and Innovation, we have developed a dashboard for the public to view progress of the program. This is available at mayor.baltimorecity.gov under the 911 diversion section on the content and on the 911 diversion section on the consent decree page. I can promise that we will continue to evaluate this pilot through our quality assurance process and identify opportunities for expansion to serve more individuals in behavioral health crises with the most appropriate and available resources. I want to also take this time to recognize the commitment of our community and institution-based stakeholders over the years in working to transform the behavioral health landscape here in Baltimore. We are a national leader, and we know that other cities are looking to us and the work of this collaborative planning and implementation committee to improve and minimize encounters between law enforcement and people with behavioral health needs and assist us with developing processes and recommendations to improve this work in partnership with BHSB as our local behavioral health authority and BCRI as a key service provider. We are going to continue to be committed to increasing investment across the region to expand the capacity of behavioral health crisis services. This is something that I am pushing my agency towards every day and work that they have and will happily continue to take on, because it's going to take all of us to establish the behavioral health ecosystem that better meets the needs of our residents. And I want to end by saying thank you to each and every one of you for your commitment, for not shying away, for not getting frustrated when money and other things don't come as fast as we all think it should, when people don't understand why we're doing this work. You all have remained committed because you know that if we're going to change Baltimore, we have to change the way that we operate. And now I will turn it over to Krista.
Good afternoon. I'm Krista Taylor. I'm the President and CEO of Behavioral Health System Baltimore. For those who don't know us, Behavioral Health System Baltimore, or BHSB, is a nonprofit that's responsible for overseeing mental health and substance use services in Baltimore City. The 911 Diversion Program enhances the behavioral health emergency response system to better serve people in need and reduce unnecessary involvement of police officers. I want to thank Mayor Scott for his commitment and leadership in initiating this pilot and supporting its expansion, as well as the reforms needed to better support health and wellness in our communities. Thank you, Mayor. Baltimore's 911 Center receives approximately 13,000 calls a year from people who need help for a behavioral health crisis. This tells us that our police spend a considerable amount of time responding to behavioral health concerns when we know many of these calls can be resolved safely without police. The 911 diversion pilot is helping to change this by having 911 call operators hand over certain behavioral health crisis calls to specialized mental health counselors at the Here to Help line. Here to Help is a 24/7 comprehensive emergency mental health helpline. Counselors will listen and provide emotional support. They can share resources for longer-term support. And in the event of an emergency, they can send a mobile response team to meet people wherever they are in the community and provide care on the spot. We are so grateful for the $2 million in federal funding to help expand this important program. Thank you to Senator Van Hollen for your work to help secure this much-needed funding. With this funding, we'll expand the pilot to serve more people calling 911 with a behavioral health crisis, in particularly children and youth. More than ever, children and youth in our community are feeling distressed and disconnected. Very recently, the CDC reported an increase in anxiety, depression, and suicidal thoughts among youth. The federal funding will be used to create a youth-specific mobile response team that goes into the community to provide care and follow-up support. This funding will also be used to hire a mental health clinician to work in the 911 call center to support 911 call takers with de-escalating crises and conducting screenings to determine the most appropriate response. These two components will continue shifting Baltimore away from a historical law enforcement response to one where people and their families get the immediate help they need in the community for a mental health crisis. I want to thank a few people that have helped make this happen. Again, Allie Smith at the Mayor's Office for your leadership and partnership. Chief Niles Ford, Dr. Ben Launer, and Captain Scott Brillman for diligently working through all the details at the fire department. Commissioner Harrison for his commitment to promoting a health response rather than police. And Baltimore Crisis Response for ensuring the services are readily available. Thank you, Jonathan, and to your staff as well. The Here to Help line is an incredible resource to help people who are in crisis or may just need assistance with finding services. I am asking all of you to please help spread the word about Baltimore's 24/7 helpline. Call the helpline anytime at 410-433-5175 to connect with a counselor who can provide confidential emotional support. Thank you. And at this time, I get to turn it over to Jonathan Davis from Baltimore Crisis Response.
Thank you, Krista. My name is Jonathan Davis, and I am the Executive Director for Baltimore Crisis Response, Inc., also BCRI. BCRI is excited to be in partnership with the Mayor's Office, Behavioral Health System Baltimore, the Baltimore Police Department, Baltimore Fire Department, and others to support the least police response when possible and connect people experiencing crises to the most appropriate resources. We know that this approach in providing our community with the most appropriate care response during incidences are best practices as it relates to public and private partnerships, access to appropriate mental and behavioral health resources, and community reconciliation efforts. 911 diversion is aligned with guidelines from the Substance Abuse Mental Health Service and Administration, and BCRI's primary role in this pilot is to provide behavioral health support. Therefore, the goal of 911 diversion is to reduce the involvement of police in behavioral health crisis and connect individuals with the most appropriate resources and support. This is how 911 diversion works. 911 call center will transfer 3 behavior call types to BCRI. The first call type, behavioral health concerns without violence, including mental health and substance abuse related crisis without a communication of injury to self or others. An example would be anxiety or panic attacks, depressed related symptoms. The second call type is suicide ideation without violence. Here's someone who is thinking about suicide but does not have a plan to die by suicide. For this call, counsel conducts a suicide risk assessment to determine acuity. In these situations, we complete a safety plan and follow up within a few hours and a few days afterwards. The third call type, suicidal threat with intent, threat and or plan. Due to the acuity of this call, 911 call center provides a situational report to the BCRI counselor. Afterwards, the BCRI counselor engages the call, and based on the circumstances, both the 911 call center staff and BCRI staff believes that the call would be best handled by BCRI. At that time, 911 call center disconnect and BCRI provide services to that caller. Also, BCRI manages the Here to Help hotline. 911 call center may transfer additional calls to BCRI. Additionally, BCRI conducts follow-up on every 911 diversion call that provides a number. We use the Columbia Suicide Assessment for each of our calls. BCRI will refer a mobile crisis team if the caller's presenting problem cannot be addressed over the phone or if the caller requests a mobile crisis team. Mobile crisis teams will provide on-site support if appropriate. BCRI may facilitate a co-response if appropriate. The mobile crisis team will remain on site until an officer arrives. Also, our hotline will follow up on all mobile crisis team support. I would like to remind the community and encourage you that you may call the Here to Help hotline at 410-433-5175 should you experience a behavioral health crisis and need support. At this time, I will turn it over to Director Riddick.
Good afternoon, everyone. My name is Tania Reddick, the City of Baltimore's 911 Director. Thank you, Mayor Scott, for your leadership, and a special thank you to all our partners for your support and participation in the 911 Behavioral Health Diversion Pilot Program. As stated before, 911 has been diverting multiple behavioral health related calls to train mental health clinicians through the Here to Help hotline. This program allows citizens that are experiencing a behavioral health or substance use crisis the ability to receive the most appropriate resources to fit their need, while reducing the over-reliance of law enforcement, EMS, and the fire department. As the City 911 Center moves towards a next-generation environment, the ability to send resources will extend beyond police, EMS, and fire. In the future, we will see behavioral health clinicians, nurses, and physicians co-located within the 911 Center to work closely with the 911 specialists to help provide an advanced set of skill, expertise, and resources to 911 callers. Furthermore, in the near future, technology within the 911 Center will be far more advanced than just communicating through a phone. Soon, you will see 911 centers communicating with video and with pictures, most like a telehealth call. We already have text to 911 and can communicate in multi-languages. This will help get the 911 caller the right resources at the right place at the right time. As we embark on the 1-year anniversary of the 911 Diversion Pilot Program, I would like to personally thank the 911 specialists of Baltimore City, the supervisors, my OEM person, the weekly QA team, the mayor's data fellows, the mayor's office, and everyone who played an important role in this pilot program. Thank you, and I present to you Dr. Ben Lohner.
I was taking notes. Thank you, Director Reddick. My name is Ben Lohner, privileged to serve as the medical director for the Baltimore City Fire Department. You're hearing a lot about 911 diversion, and that's true. We want to divert calls away from police unnecessarily. We want to divert calls away from 911. But I hope what everyone is also hearing is this program is fundamentally at its core about connection, meaning that when you call 911, we want to link the caller to the most appropriate resource. And being an emergency physician, I know that a lot of people come to the ER because it's open 24/7 and because it's there. And similarly, 911 is a broad safety net. And historically, 911 has always been sending emergency vehicles to any response. And I think we could all agree that the connection of a caller in need to an appropriate resource, specifically a licensed or a trained mental health clinician, actually benefits everyone involved. So that is where it's a very humbling experience because it's a multi-agency collaboration under the leadership of Chief Ford and Mayor Scott. It's quite unprecedented to have representatives from everyone at the table. And I can't say enough about the participating agencies because this is something that we all share a great deal of enthusiasm about. Mayor Scott also mentioned data, and that is something that is incredibly key. Obviously, in the medical field, if we can't prove something or demonstrate its utility, it's not necessarily safe. So every week we meet, and we have broad-based representation from police, fire, citizens, our data fellow colleagues, and if something needs to be changed, we adjust. And that is a core, I think, component of this program. So I think I am not saying anything surprising by saying if you look at this in another year, not only will it be bigger and better, but I think fundamentally it will change. And even in our short time, the year of operation, we have collaborated with consultants, we've collaborated with other cities, we have looked at best practices. So this is something that will continue, and the form in which it continues will be dictated by our results. And those results are most importantly caller and citizen and patient focused. So I hope you all share the enthusiasm for this project. I know there's probably a lot of questions. And for that, I'd like to turn this back over to Mayor Scott. So thank you for your time.
Thank you. Thank you, Doc. Questions, everybody? Dave? Emily?
Good afternoon. My question is.
Oh, hold on 1 second, Emily. Try again now.
Where are we now?
Nope.
How's this?
No, it's not you. It's just blinking.
Testing.
There we go.
Thank you. All right. Good afternoon, everybody. My question is about the third type of call that was added, suicidal ideation with a plan to act. Can you tell me exactly when that rolled out and what the results have been so far? Did I hear correctly that we have started diverting those calls?
So I believe about 2 months ago, we added the third call type.
Okay. And how have the results been? Are we seeing frequent 911, like frequent EMS responses to that? Is it mostly the mobile crisis unit responding? If anyone is going to the scene?
Sure. So we did add that call type several months ago. And I think what that has done so far is increased the volume measurably. We are still putting together the data in terms of diversion because it's important to understand that the call types are predetermined, meaning we try to match them to the caller. So there's always a little bit of a difficulty and inaccuracy. So one of the core metrics is try to broaden the umbrella of calls that we catch. It has done that. I would have to break it down a little bit further, and we look forward to sharing that data with you. So it has increased our numbers.
Do we have a rough timeline for when that data will be released?
So we're maybe in a couple of weeks, because we will add that, and we do have that data by call type on the dashboard, so we're talking about maybe a couple of weeks. And just to add, and thank you for this question, we want to be able to report out metrics that are patient and community focused. So if we find situations such as this, where we need to report out on a specific call type, we will certainly work to get you that information.
Thank you. And are there other candidates for types of calls that you hope to that anyone can answer this, that we hope to divert one day?
So ideally, the answer to this is we'd hope to divert every one of them, because behavioral health complicates in excess of 30% of the calls to 911. These don't live in isolation. The challenge is that when people call 911, the presence of a medical complaint is very different, and our 911 specialists that are taking the phone are answering hundreds of calls per day. So in order to increase that capacity, it is not only about the call type, it's about the addition of clinicians within the center. Because right now it's protocol driven, which limits triage. So once we have more resources, which is exactly what we're working on with this team, we hope to broaden it to anyone with that complaint. You might have heard, for example, just because we don't divert, we still co-notify. That means somebody with a medical complaint can still talk to a licensed mental health clinician. So I know that's a little bit of a long answer. It's just that the process is a little complicated. We're working to extend those resources to everyone.
Great. And final question about the...
Emily, I'm sorry, I just want to chime in there. I think that you heard us talking about evolving and changing what the ecosystem looks like, and that's why we're doing it in this way, because it's very responsible. And we also have to, make our case, right, to folks as we go along the way, not just here locally at the state level, at the federal level, to make sure that if you look at what it looks like now, right, for example, 15, 20 years ago, people wouldn't even... It'd be a pie in the sky idea to say that you can actually text into 911, but now the system has evolved into that. Now that many more people are coming into the light, as we would say, about how we need to actually have appropriate behavioral health responses and not built into our systems, then we can grow that in a responsive way over time. So in the next 5, 10, 15, 20 years, all 911 call centers, not just here in Baltimore, but across the state and the country, look different.
Thank you. And final question about the operator that's going to be added to the 911 staff, the clinician. Is that a 24/7 role? Is that one salaried person who will work 8 hours a day?
As of right now, it's still being worked out exactly what's the needs of the clinician in the center, because there's certain things that we know that needs to meet the center as far as dealing with the calls in itself. So we have to make sure they're trained. They have to partner with not only the fire department, but as well as the police department and everything else to see what fits the needs, and based off the data that we get from the call types that we're using, the 3 call types, and then it will determine what's the need of the clinician, if it's based off of just a several time frame of a day, or is it based off of 24/7.
Got it. Thank you,
You're
everyone.
welcome. Thank you.
Mr. Gatlin?
Dave from
Oh,
Channel 2.
somebody else wanted to talk, chime in? Come on, Kristen.
Just to echo, I just want to say there is funding available for 24/7 coverage as needed, depending upon the data and what is learned from the center.
And I don't know if this piggybacks off of Emily's question, but with that data, how many times the mobile crisis team has been deployed since its launch? Can you give a specific number?
Yep, if we click over, we might be able to just show you that. And we'll make sure you get the link too, Mr. Gatlin.
Okay. And since you
One
guys are
second.
taking... There we go. So 47, roughly? Okay. So that's out of the 501? Out of all the 501, 47 of them
And
have
30
involved mobile?
Yeah, 30
Okay.
was resolved by BCRI over the phone.
But in terms of the mobile,
Yep,
it's
it's 47.
And because you're dealing with such a vulnerable population, do you have caseworkers who are monitoring these individuals who are calling in? That way you can possibly track repeat callers, and then I'll ask my secondary question.
Yes, so we do have a system in place to allow us to identify repeat callers if we have a phone number, but we do have follow-up calls conducted on every call.
And is there interagency communication between all of these, plus fire, police, so that if these individuals who are displaying behavioral issues that could lead to a criminal incident, can you explain what that communication system looks like?
So I think, sir, you've just earned your space on a task force, actually, which is great. So meaning that, and this is a great question, the population is extremely vulnerable. The population, also a significant percentage of them are undomiciled. So it's very difficult to track patients that encounter multiple different systems. So if you were to ask me right now how we get to repeated callers, number one, some of the information is protected by law, and we want to preserve patients' privacy. There are all sorts of laws and regulations with behavioral health emergencies. And the second thing, I know it may seem counterintuitive, but it's very difficult to track. So one of the things that has come out of this collaboration is that multidisciplinary group, which involves homeless services. We've recently onboarded the health department, different social workers, and we would like to have a program that eventually has what's called, as you're referring to, full wraparound services. Right now, that's being operationalized because of some of those challenges, but that is a significant challenge, as you mentioned, because we see those patients in the emergency departments, we see them calling 911. So working on that capacity.
Mackenzie?
Hello. When we talk about the ecosystem, I know that this is obviously a big part of what the city has been pushing for in the diversion program. A lot of the data is really interesting. You've also talked about partnerships with other people in the criminal justice system. Yesterday, there were a lot of questions about the partners from the state's attorney's office perhaps dropping the ball with some of these cases. Are you concerned about the prosecutor's office not doing their jobs when they're getting cases from the police that are then being dropped or pled down to lower cases?
I think I've been very clear about this, Mackenzie, which is why I went out to the governor and asked to restart the Criminal Justice Coordinating Council that had been dormant for over 3 years. I'm concerned about every single part of the justice system. Everybody that works in the justice system has to do better. But I always start with myself and push myself and my police officers to continue to do great work and expand upon that great work, right? Because we could have a conversation about every single agency involved clearly with a city and a state that's been struggling in these issues for many, many decades. Clearly, this is a system that has to be changed. This is why you hear me talk about bringing all of those folks together to say, where are the gaps? How is it that this young man long before any of the elected officials here were elected, right? Back in 2000 and whatever, had a sentence that was shortened. Why is it that we consistent? What happened with him while he was there? What kind of rehabilitation did we see? Was there some behavioral health work? Was there some substance abuse work? Was there some job training? And then why is it that when he came home, what were we doing? Why weren't we supporting parole and probation that's severely underfunded? Why is it that these kind of cases are played in that way? The whole system, everybody in the system has to be better. Every single person.
Does that include State's Attorney Marilyn Mosby?
Is she a person in the system? Everybody has to be better. Everybody has to be better in the system. I have to be better. The police department has to be better. And we are much better than we were a few years ago, and we're going to continue to be better. But this system, this is a system-wide issue that has to change. Thank you. Anybody else? Thank you so much.